Welcome, and thank you for inviting me. This is a tremendous program. I'm very excited. I wish I could be there with you. I hope in the future I'll have a chance to visit and join your meeting in person. But this has been wonderful, and I am thrilled to be part of it. My task today would be to complement many of the previous talks about complex problems involving the distal radius. And in this case, an area of my particular interest is distal radial ulnar joint problems. I'd like to begin by showing two particular cases that I think represent some various different problems that we commonly see with distal radius fractures. Here is a patient that is approximately 2 years out that gradually developed greater and greater DRUJ instability until it became symptomatic. This is another case that I recently treated that was fairly acute fracture, a very severe fracture that was plated at another institution. And as you can see here, she has dorsal instability. She essentially lost all forearm rotation and had continued pain on the ulnar side of the wrist. So what I'd like to do now is to discuss some of my approaches to complex distal radial ulnar joint problems and then come back to these two cases. Certainly the most common reason for DRUJ problems is complex distal radius fractures that create problems all along the ulnar side of the wrist. But not only is the distal radius the problem, as we've heard in previous talks, the ulnar styloid and TFCC can be disrupted, the sigmoid notch may be disrupted, the secondary soft tissue constraints such as the ECU subsheath, the capsule of the distal radial ulnar joint, perhaps the pronator quadratus. We also know the ulnar head is important. Fractures of the ulnar head can be involved. And then finally, the interosseous membrane, including the radial head with longitudinal disruption of the DRUJ can occur. So all of these areas are important, and if you do not recognize that and only isolate one particular area, then many times you will not solve the patient's problems. I think one of the more interesting recent developments over the last 10 years has been a greater understanding of the interosseous membrane, and in particularly the distal oblique band of the interosseous membrane, which we've heard about and Dr. Orbe has discussed frequently. I think it's been very important to recognize how it's influenced our treatment of distal radius fractures over the last decade. And that is, we knew the TFCC was often disrupted and other soft tissues were also disrupted, and yet the DRUJ was not necessarily unstable. And I don't think there was a good answer for it until we recognized the importance of the distal oblique band. And here you see, this is out of a paper that was published almost 20 years ago now, showing that more proximal distal radius fractures were actually more likely to be stable after fixation than a distal radius fracture. And that was basically a paradox. I don't think we thought that should occur because you would think that there would be more disruption. But in fact, it was probably the distal oblique band that keeps most of our Galeazzi fractures from becoming unstable after we've fixed the radial shaft. So I think this has been very helpful in my understanding of the distal radial ulnar joint in complex injuries. And in fact, there are now reports showing the ability to reconstruct the distal oblique band. I have not yet had the opportunity to do so, but many others have throughout the world. And I think we're going to see more publications about the reconstruction of this and the importance of it in restoring stability. In my practice, I really rely on dynamic testing for unstable DRUJs. I think we're often relying heavily on our piano key test and a manipulation of passively of the distal radial ulnar joint. But I think it's more important to actually have the patient show dynamic instability, because this represents more of their actual symptoms. And then here you see what I call the modified press test, in which the dimple, if you will, showing up over the ulna, because the radius is being forced dorsally and the ulna into the table. Another key factor is lifting in supination rather than in pronation when we rely on the soft tissues. This is a recent study that we did showing the different ways you can take intraoperative x-rays, in this case fluoroscopy, to identify DRUJ instability, and looking specifically at the dorsal tangential view with fluoroscopy. And in fact, what this view showed was that it actually has excellent accuracy in all forearm positions, neutral, pronation, and supination, and there was good intra and inter-observer reliability. So perhaps this can be used as a complement to the other views that we use in the operating room to assess the instability after the distal radius is fixed accurately. I think we all still rely on CT scan for our chronic instabilities, but MR scan can also be helpful. What I'm looking for in these is three main factors. One, is it dorsal instability, volar instability, or bidirectional instability? Number two is what's the shape of the sigmoid notch? And number three, is there early post-traumatic arthritis? As we've heard a couple of times, there is certainly a great role for arthroscopy in assessing the integrity of the TFCC. And I won't go into this further, but I do agree that it's important in both the assessment and the treatment of distal radial fractures with continued ulnar-sided wrist pain and DRUJ instability. Don't forget that even though we're surgeons, there are, I think, increasing number of braces that can be effective for mild instability of the DRUJ. On my left here is the digit widget, which was one of the first. On the right is called the bullseye. I've managed several patients per year using these braces for patients with mild instability, and they become very, I guess, less symptomatic, not completely cured, but they're able to tolerate activities of daily living and even some sporting activities. So don't forget to try these before you would go straight away to surgery. It's certainly controversial when we should, when and how we perform TFCC repairs for DRUJ instability. I'm not going to talk about TFC repairs for the stable DRUJ. I think there's two remaining controversies. Should we do a foveal or a capsular repair, and should this be open or arthroscopic? And in my opinion, it really depends on the severity of the instability and the TFC injury. If you look at the literature, it basically says that the two are equivalent, that there's no great benefit from one over the other. But I think this is a little bit difficult to really separate out this group using this literature. Nevertheless, I think it's important to recognize that both can be effective if done properly. Our primary goal is to restore the TFC attachment, as we know, to the fovea if we're going to try to treat a severe instability, because this is where the main focus of the TFC attachment is at the ulna. The problem with capsular repair and a severe instability is that it really leads to, as I show here, like tying up a boat. There's too much laxity, so it becomes sort of a floating repair, if you will, if it's done to the capsule. I think transosseous repairs can be done either arthroscopic or open, but if they're done arthroscopically, it can be difficult if the trajectory of the wires doesn't put it right through into the fovea. As you can see here, sometimes it'll actually go out through the ulnar head. So I think it can be very difficult in some patients to do it arthroscopically, a transosseous repair. However, I do think arthroscopy is particularly helpful in some isolated cases, even in severe instability, like in an ulnar styloid non-union, because you can use arthroscopy to assist an open repair. And in this case, the ulnar styloid is resected, and now under direct vision, transosseous sutures can be placed through the ulnar neck and into the fovea, and then guided arthroscopically into an exact position through the TFC without damaging the ulnar head or the TFC. So my general treatment algorithm for DRUJ after a distal radius fracture or at the time of an acute fracture is as follows. Now, this is assuming the distal radius is accurately reduced. In the mild or subacute, I will usually perform an arthroscopically assisted TFC repair, as we've heard in previous talks. In the mild to moderate, subacute and chronic, I prefer an open repair because I think I can prepare the fovea better. I can treat the TFC better by greater tension. And then in the moderate or the chronic group, I will consider a ligament reconstruction and actually even a sigmoid notch osteoplasty, as I'll cover here in a moment. I prefer a dorsal approach through the fifth compartment. I think this gives great access to accessibility to the TFC and the fovea without disrupting the ECU subsheath. I do not open the ECU sheath during my repairs. And here you can see this patient had a combined arthroscopy to evaluate the joint, followed by an open repair. It's important not to disrupt the distal radial ligaments when you're doing the exposure. But as you can see here, you get an excellent profile and an excellent reattachment to the fovea and through a very small incision. Greg Bain actually introduced the concept of adding augmentation to the TFC repair using a palmaris longus graft. I don't think there's too many indications for this, but this is something to consider if the TFC is otherwise with good integrity, except for in its more peripheral margin. Ulnar styloid fractures, just a few little pearls that I would recommend in related to these, as we all know, they're very common with distal radius fractures. In fact, 70% of distal radius fractures will have an ulnar styloid. The literature would tell us that it doesn't really affect the overall outcome of distal radius fractures when we look statistically at large groups, nor does the size of the styloid fracture tend to affect the outcome. However, I think it still remains controversial if styloid fractures really correlate with DRUJ instability. There's been some various different mechanisms to treat displaced ulnar styloid fractures, but I think often the hardware becomes very irritable for the patient. So the less fixation that we can use, the better. There's often descriptions of using screws and wires and tension bands, but these can also irritate the patient. One mechanism I've used for some time now is actually with or without using a suture anchor placed down the shaft, but you don't even have to use a suture anchor. You can use a drill hole, a transverse drill hole through the ulna, and do a tension band around the fragment and back to itself, as I show here in these two pictures from my video, and that provides good fixation of styloids. So this can be done very quickly at the same time as you're fixing a distal radius fracture and restore stability. And here you see a couple of cases. Here, wide displaced DRUJ. You can see after the distal radius is fixed, the styloid is still widely displaced, and by using a simple suture anchor technique with tension band, it can be brought back down for healing. And here's another case, in a chronic case with DRUJ instability, in which the TFC is again repaired by fixing the styloid back. Remember, however, fixing the styloid back will not work if the radius is not out to length. The TFC simply won't make it to that level. And so that's contraindicated. Either an ulnar shortening or a radius osteotomy is needed in order for the TFC to have sufficient length to reach its normal foveal attachment site. And in fact, that leads to my next treatment. Most distal radial ulnar joint instabilities don't even need a soft tissue repair, as we've all been to. We all have had the opportunity to fix. Simple ulnar shortening is often restorative of the DRUJ stability. So I believe in keeping it simple. And in fact, if there's a malunion of the radius with shortening, I'll often fix only the tilt of the radius at the time and then shorten the ulna to match, rather than trying to lengthen the radius at the same time. So here's another case of chronic ulnar impaction, DRUJ instability, and a peripheral TFC repair, all treated by ulnar shortening. So it is my preference to shorten the ulna, restore the stability the best you can, reassess intraoperatively, then proceed with soft tissue restoration if needed. And here's even a case that's very chronic, and I thought I would have to do a ligament reconstruction. but I didn't. Even just a simple shortening provided complete stability back to this patient. One trick that I like to do is to perform my shortenings in the arthroscopy tower. This provides the ability to support the patient's arm so that you don't need as many assistants. It allows you to do your shortening procedure very accurately and rapidly to get fluoroscopy in. And then after that, if you need to do an arthroscopic procedure after shortening the ulna, now the ulnocarpal joint will be more distracted and it'll be visible and easier, and you're already ready to proceed. So consider using an arthroscopy traction tower in your ulnar shortenings. Concerning ligament reconstruction, I proceed with this. If the TFCC is not of sufficient integrity for direct repair, remember, skeletal alignment must be optimized before you do any soft tissue repair, particularly ligament reconstruction for chronic cases, or it just won't work. And most of the time when I hear reports of patients, surgeons saying they didn't get a good result, it's because the geometry and the alignment of the bony construct hasn't been restored. As many of you know, this is a technique I've liked to use for years. It still works well in my hands, but I've learned a lot of little tricks of the trade, if you will, to make it happen, to perform it more efficiently and accurately. Some people have even performed it arthroscopically. I think that this can be done, but it can be quite challenging. And it also puts the graft intra-articular, and I prefer to keep the graft extra-articular in my reconstructions. Again, the goal is to restore the ligamentous structures back to the fovea, which it does. One of the key factors of the reason why it probably works is it actually incorporates the ulnocarpal joint ligaments on the volar side and restores these back down to the fovea at the same time that it reconstructs the radial ulnar ligaments. And I think this is the main reason why it's effective. And in fact, it's similar to an arthroscopic procedure where people tighten the ulnocarpal ligaments by themselves. And here you can see volarly how much the graft actually covers and draws in the volar wrist capsule. Many times there's difficulty in finding an adequate graft length. I know many people, including me, have found the palmaris longus to be too short. There are other grafts that are available, including allograft. But my preference is to use a palmaris longus or a partial, a strip, if you will, of the FCU. And one trick I use more recently in the last few years is not to try to go all the way around the ulnar neck as I originally did, but sometimes it's easier to just wrap it around the ECU sheath at the ulnar neck after extracting the ECU tendon. As I show here in a cartoon, it's pulled out, and then one limb is passed under it subperiosteally, and the other limb goes over the sheath but under the tendon without taking the ECU completely out of the sheath. Remember, any soft tissue reconstruction after a distal radius fracture is likely to fail if the sigmoid notch is flat. And so one of my first failures in ligament reconstruction was actually due to this. So if you see something like this with a flat sigmoid notch, either from chronic instability or after a distal radius fracture in which there is loss of the volar rim of the sigmoid notch, then something needs to be done to reconstruct this. And here you can see such a case with the amount of volar instability. I like to use a modification that Walwork and Bain described, in which it's usually on the volar side. He performs a osteoplasty, as it's called, of the sigmoid notch. It's simply putting an osteotome in through a small area and then levering that to recreate a better rim, and then a graft is placed behind that. And it looks, it really changes it. And this has dramatically changed the stability for some patients. It can even be combined with a ligament reconstruction. And that captures the graft and holds the graft in place. Here you can see such a case in which a ligament reconstruction and a notchplasty has been performed that restored a DRUJ instability. And it can be done through a fairly small incision. Here's one of my very first cases in my first publication on the technique. And if you do an osteotomy, if you need to do an osteotomy at the same time as a ligament reconstruction, I recommend that you do the radius osteotomy and make the tunnels for the graft at the time before you pass the graft. And as you can see here, that restored both the radius and the DRUJ. So let's come back to the two cases that I have. And here it is, for the sake of time, my findings for this patient were a widened DRUJ, an ulnar styloid non-union, but not much of a radius malunion. You can see that the carpus is very well aligned. The lunate, the scaphoid, and the capitate are all still very well aligned. So what are our treatment options here based on the presentation I gave? Well, in this case, I think we know that the DRUJ is widened, and we know this is the chronic case. So what would we do next? Well, I think we need to know what the integrity of the TFC is. So I prefer to get an MR scan if it's available. And here you can see it's a very thick TFCC, and it's a flat sigmoid notch. So I know I have soft tissue available, at least consider a repair rather than ligament reconstruction. But I also have to consider the flat sigmoid notch. And if I go above, you can see, or go back, you can see how flat the sigmoid notch appears even on the plain radiographs. So what was done in this case is a combination of the styloid excision, an open TFC repair directly to the fovea, and a notchplasty. So I think in this case, again, it can all be done through a limited exposure and restore the anatomy. Back to our other chronic case, I'd like to show, this is one of more exciting cases I've had recently. This was actually a surgeon who presented with this after a devastating fracture, and she had actually no motion in forearm, locked in essentially neutral rotation. As you can see here, the ulna is out dorsally. Another surgeon had tried to go back and restore the sigmoid notch. They tried to fix the styloid, and they pinned the DRUJ. But however, once the pins were pulled, you can see that the ulna is out dorsally again. It happened almost immediately, and again, she lost all motion. If you look carefully at these x-rays, what's intriguing about this is look at the shape of the ulna. So it's highly angulated. And so the surgeons had really put emphasis on the distal radius and forgot about the total bony anatomy. In this case, the ulna was quite bowed, and it was somewhat of a natural bowing that she had even on the other side. But there was no way to restore this with soft tissue. And they were considering doing an aptus procedure or a DERA or other more salvage procedure. But in this young surgeon, I thought it was not the appropriate thing to do. So I did something that Dr. Paul Dell described many years ago, and that's doing an ulnar osteotomy. And I overcorrected her, and I placed her ulna actually into a volar position and realigned the radius to the ulna. And I don't have time to show all of her videos, but to this day, she's now back at work delivering babies and doing C-sections and other gynecological work, and she has near full pronation supination and a stable DRUJ. So I close with this case because so often I think we think of the TFC and ligament reconstructions and the radius as the problem, but occasionally it can be the ulna also after a bad distal radius fracture. Thank you again for allowing me to join with your program, and I hope I gave you at least a few pearls that can be helpful in your practice.